Sir, I'll just make a quick this on the resume part. If you can please manage the watch party stuff.
Or you begin with introduction, I'll start the watch party and I'll proceed with the resume part.
An admin
Acha,
approved
chalega.
your...
I think it's written.
I'll do the
Streaming
introduction.
live on Facebook now.
Yeah, it's live. Hello everyone, welcome to WDA. Good evening. Today we have topic of contemporary pediatric dentistry, A to Z of essential tools. We all are in love with dentistry. We all love treating our patients in best possible way. But when it comes to treating kids, our heart skips a bit and we are a bit hesitant or skeptical. We all try to give our best in terms of approach and armamentarium. But do we have all which constitutes best? Are we all updated with the latest to provide the best? In the last 2 decades, there has been significant improvisations in the way pediatric dentistry is practiced with all contemporary upgradations. This 75 minutes lecture on esteemed WDA platform covered by a duo of exclusive pediatric dentists from Pune and Greater Noida would creatively focus on contemporary components of pediatric dental practice through 26 alphabets, each highlighting about CPD. This includes the pediatric dental team qualities and essentials, new clinical behavior management techniques, novel materials, approaches, and techniques for pediatric endodontics, orthodontics, and aesthetics, camera and preventive protocols, nitrous oxide sedation, its continuum and dental GA, and a lot more when it's about giving all options to our children or parents. Best shall always be an option. Today we have Dr. Sanchit Paul and Dr. ABHISHEK SONI with us. I'll hand over to Dr. Swapnil for the brief introduction. Dr. Swapnil, are you here?
Yes, sir. I'm here. Am I audible?
Yes.
Yeah.
Yeah. Good evening, friends. We are very honored to have this dazzling duo of Dr. Sanchit Paul and Dr. ABHISHEK SONI, sir, at our platform World Dental Association. Both of them have been the Manipal University from Mangalore. Both of them have finished their PG in 2013 and have been into specialized pediatric practice since then. I am giving a very common introduction of both of them, and as both of them work in almost a synonymous field, I'd like to mention both are exclusively pediatric dentists. They don't entertain any of the other dental aspects, and both have been passed out from Manipal and have won various accolades with FAMDent. They've been awarded Best Dental Clinic in India, then Best Pediatric Dentist, then the Pediatric Dental Clinic in India by Indian Health Professional Awards, and various other accolades. So I'd like to welcome both of them to our platform, and stage is all yours. I'd request Dr. ABHISHEK SONI, sir, to please kickstart the program.
Thank you, Swapnil, sir.
Thank you so much for the kind introduction. Thank you. Just want to take a quick minute to thank you, the whole organizing team of WDA, Dr. Abhishek Mahajan, Dr. Anand Mohta, Dr. Swapnil, Dr. Ashwani to be here. What we were looking forward is that WDA has been fantastic in showcasing each and every specialty, but we just thought that we might be able to, would like to highlight some about pediatric dentistry. This presentation is just an attempt to give an overview about it. So let Dr. Abhishek take it over from here.
So thank you, team WDA, for trusting us and allowing us to showcase our zeal for passionate pediatric dentistry. When we talk about pediatric dentistry, the first word that comes to our mind is challenging. And as we climb the ladder in the pursuit of delivering the best pediatric dental care to the little ones, we are faced with a plethora of challenges in our practices. This A to Z is a small attempt on our part to help you all overcome the same with ease, joy, and glory. So this presentation basically keeps itself abreast with the contemporary materials and the ways to best manage a child to depart your dental care center with a positive dental attitude. Through this presentation, we wish to give you all a holistic view about the A to Z of contemporary pediatric dentistry. The first half will be covered by myself, and the second half I'll be handing it over to Dr. Paul, who will be taking up from letter N. So before we begin, we wish to convey that we don't have any conflict of interest. This is not a sponsored lecture. What we showcase is our own materials that we use in our day-to-day practice. So let's begin the alphabetical journey with the letter A. A for audiovisual aids, a must-have distraction tool in your practice. Let the children use it once, and trust me, you'll see the magic unfold in your practices. There is plethora of evidence supporting the musical therapy, the audiovisual aids, and all conclude that there was a significant difference in the pain and the behavior when comparing the audiovisual group and the control group. So what we use in our practices is basically a beautiful amalgamation of AV aids and nitrous oxide oxygen inhalation. So what used to be noise, the cry of the child once upon a time, will be music to your ears as most of the little ones depart happily from your dental center. So these are the virtual reality goggles and the earphones for the audio analgesia. And see the difference it actually makes. It calms the child in not so threatening environment. Now, the audiovisual aids should not just be confined to your dental practices. Your audiovisual aids can come to help with behavior shaping and management of not just the child, but with the parents alike. So communication can actually start through your website as a modem for your audiovisual aids to establish a sense of security. Parents get to see all your cases that you've uploaded on your website, and they know what they're in for before they actually step into your clinic. So although a vast topic to cover, but trust me, pediatric dentistry cannot exist without the essential behavior management tools. McElroy rightly said that if you've completed the best of your pulpectomies, the best of your crown, but if the child departs crying from your dental center, that treatment visit is a failure. Your basic behavior management will actually start with parents preparing the child from home. So we are all aware about this triangle where the child is always at the apex, but let's not forget the important role of parents and society. So we all come across unaware parents, we all come across ignorant parents, but in the age of information, we believe that ignorance is just a choice. And we try beating our heads around trying to explain them the importance of milk teeth, the importance of early intervention, the importance of establishing a dental home, anticipatory guidance with us. Because all the parents, most of them are either misguided by the peers or they have been misguided by their healthcare provider. They all believe that these are probably temporary teeth, so they're going to fall off. So it's important that we as dentists build up a dental home for them as early as possible and impart them about anticipatory guidance. So we all come across these millennial parents. These are those specific helicopter parents who will be hovering all around, seeing what is happening, and they will have high parental expectations from your end. But then reality strikes hard. So this is how we actually meet children in our practices. And that's when the superstar effect or the superhero image that the parents had about us actually changes, and everything boils down to this pleading and this begging the little one to actually open his mouth. And I'm sure we all can relate to this image. But stay calm. Remember that you are the boss. Remember that effective communication. There will always be some demographic difference, While my website does all the talking for the parents, at Dr. Paul Center in Greater Noida, he is the effective communication maker over there. So please understand that you guys are going to be the decision maker for the child. So your behavior management, which has in some parts started or begun at home, make sure that your waiting room starts speaking for you. It should speak loudly about the principles that you stand for in delivering quality dental care. It should have tidbits about how laughing gas can be used, about how camera protocols can be incorporated into your practices. Create that the enthusiasm in the parents that they themselves should come and ask you about camera, about laughing gas, and all the preventive protocols that are in place. This is how we have at Vanilla Smiles Pune, we have these audiovisual aids to our advantage in the waiting room where everything is just running around. So let's look at a typical first dental visit and how do we go about with it in Pune. I'm sorry. So you saw that was an amalgamation of parents, the child, and how some amount of tender care can actually make a difference in the child's first dental visit. This is a small video showcasing how it's being done at Tooth Tales, Greater Noida. So please don't forget the positive reinforcements. Make sure that each dental visit is positive. So let's look at caries management by risk assessment. That's camera. We all know that dental caries is a biofilm driven disease. The onus is on us as operators to identify the individual risk factor for that particular child and eventually engage parents through adequate counseling into dental home and anticipatory guidance for the same. We have to decide whether we wish to be a chief complaint pediatric dentist or the one that provides a holistic view so that the child once treated does not come back with new cavities. And even if the child does return back with any new cavities, make sure that all your follow-up protocols are so stringent that any new cavity can be managed in the most minimalistic manner. So in a nutshell, this is what camera stands for. And you can find a lot of reading matter about this on the AAPD guidelines or the AAPD website, which talks about the caries management protocol for 3 to 5 year olds, the greater than 6-year-olds. And there is plethora of evidence, and it can help us into how to tip the caries balance towards remineralization rather than demineralization for that particular child. So we proudly present ourselves as camera dentists, and we have posters put up in our waiting room. So what is camera? It basically is a meticulous amalgamation of homework and classwork. Homework, which has to be done by parents, and classwork, which involves your regular fluoride varnishes, your oral prophylaxis, your interproximal flossing, and your administration of your cavity fighting liquids, depending on the risk category of the child. Now, depending on the risk category of the child, let's look at an example. If it's a low risk child, it's beautifully given as to what home hygiene protocols the parent should follow in all the pamphlets that are shared to the parents. It also includes the clinical protocols which you as an operator will be doing for that particular child, depending on the risk assessment, whether you will be seeing the child every 3 months, 6 months. If the child is under high risk, maybe you want to do intensive fluoride regimens for which you may have to see the child every week. And then eventually, once the home hygiene protocols are in place, you see some signs of arrest which are imminent, and you start moving the child to a moderate risk, and then eventually start seeing the child every 3 months. Then again, evaluate whether the parents are following the home hygiene protocols or not, until the child falls into a low risk category, and you eventually start seeing the child every 6 months. So soon you'll realize that your interproximal flosses, your 1,000 to 5,000 parts per million of fluoride dentifrices, your remineralizing toothpastes, they'll all become an integral part of the home hygiene protocol for the parents. And along with your topical fluoride varnish regimens and your interproximal SDFs in office. So as we move towards minimal invasive pediatric dentistry, let's be minimally invasive in our pulpal procedures also. With the advent of bioceramics, what was a contraindication once upon a time is now an indication that finds place in the American Academy of Pediatric Dentistry guidelines, your direct pulp capping, which shows a success rate of around 88 to 90%. And a recently submitted review which talks about the direct pulp capping outcomes in cariously exposed pulp. So a lot of us begin with the end in mind, wherein we are reading the radiographs. We see that the cavity is probably ICDA 6, and we inform the parents that this particular tooth is going to need a root canal treatment. However, you have to amalgamate your clinical signs, you have to amalgamate your radiographic signs, and eventually go selective removal, and then decide whether the child needs an indirect therapy, or whether the child needs a direct pulp capping, or whether the child needs a pulpotomy, and then your pulpectomies come into picture. So now there is enough evidence that we put a stop on invasive pulpal procedures. And that is only because of the presence of bioceramics that is available in our practices. That includes your biodentine and your MTA, which are available. So let's look at the role of biodentine in this specific study, where they talk about the inflammatory cell response. So if you see, the inflammatory cell response was grade 1 for all the 20 teeth treated with bioceramics. And that's because this is a purified product. So let's look at a clinical scenario. This was a child who was treated under general anesthesia, under strict sepsis, and under rubber dam. You can see these restorations which are failing. You can see a lot of secondary cavity under the restorations. And we started with non-selective removal of the carious tissue because we wanted to be definitive, since the child was being treated under general anesthesia. So you can see 7475 non-selective removal. You had a pulpal exposure with 74, and you can see the shadow of the pulp in 7.5. However, there was no carious pulpal exposure with 7.5. So we chose to do a biodentine IPT and a biodentine DPC in 7.5 and 7.4 respectively. So biodentine was packed and 7.4 was crowned, whereas 7.5 was restored with resin modified glass ionomer stemming. And that's the clinical and the radiographic outcome. So both the teeth are doing well and are stable. Another case of direct pulp capping, wherein we tried to be minimally invasive. These are elastics, which we shall cover shortly in the Hall's technique. So we tried to do an aerosol-free pediatric dental procedure by putting the elastics. But if you see in the clinical picture over here, the elastics have sunk subgingivally, and we could not achieve that kind of separation which we ought to have. We started with selective caries removal, and we encountered a carious pulpal exposure. We decided to disinfect this with 1.5% sodium hypochlorite. We did the crown selection first, disinfected with sodium hypochlorite, irrigated or flushed with saline. The exposure site was covered with biodentine entirely, including the cavity. The crown selection was already done, so the crown was eventually luted into place. And that's the 22 months follow-up. It's all stable. So we all are aware about how rotary endodontics has revolutionized our practices and the way we do root canals. We now have pediatric rotary files which are about 16 to 17 millimeters in length at our disposal, with various tapers provided by ProAF, Baby Gold, and your Keto SG pediatric rotary files. And there is a lot of evidence besides making the procedure quick, which is important when you treat these little ones, about wrapping the procedures fast. So this study concludes that the post-operative pain after pulpectomy in primary maxillary molars teeth, when compared to the rotary system, was less for the rotary file systems. This was an in vitro comparison as to the amount of time required for hand files versus pediatric rotary files, and there was statistically significant difference that was seen. And rotary instrumentation was effective in smear layer removal for root canals treated with rotary files. So that's the single visit pulpectomy protocol, wherein we are following a hybrid technique. We start with 15K file. We usually don't need the 10K files because the canals are already wide in a young primary molar. Once hand filed until 20K file, we shift to our end of flare, followed by our Pro AF BB series, which I like. Dr. Paul follows Keto SG Blue files. And we have shifted to using Twin Clean as a single irrigant, wherein we combine 2 capsules of 0.45 grams of Twin Clean along with 10 ml of 2.5% sodium hypochlorite. So the drops that you see is the irrigation protocol. That is, after each filing, make sure that your canals are moist. So let's look at the tips and tricks. It's very difficult to cover everything, but it's important that we read our radiographs well. So what is it that we need to look at? So first thing first, your radiographs is going to help you decide as to what taper of file that you're going to use. A lot of secondary dentine formation happens as the child ages from 3 years to 5 or 6 years of age. So when you take a radiograph for a child who is 3, you will see that the canals are wide. So you probably may need a 4% or a 6% taper files. For a 6 or a 7-year-old, you may have to start with your 15K file, your 20K file, which is 2%, and then gradually move on to 4%. Your radiographs, the most important area is your interfocal area, wherein you have to check for any radiolucencies, if any, and then eventually decide whether the tooth needs a pulpectomy. Because of the focal accessory canals, the focal region is the first area is where you will start seeing your radiographic changes. So if you see in the left radiograph, you will see that there is focal radiolucency, which is suggestive that the child needs a complete root canal or a pulpectomy treatment. On the right side, when you see the radiographs, you see that the lamina dura is continuous. You don't see any radiolucency in the fulcral region. You see an ICTA6 lesion, which is approximating the pulp. However, you can still decide whether the child needs an indirect therapy because it's a 2-dimensional exposure. So everything has to be clinically based eventually. So after you have done your selective caries removal, and if you don't have any exposure, you can disinfect the floor, you can disinfect your cavity with sodium hypochlorite and just go in for IPT. If you have a pulpal exposure where you have profuse bleeding at the exposure site, and which is not being able to be controlled with your sodium hypochlorite or your pressure pack, then you know you have to go into your pulpotomy. After your coronal pulp amputation, after 3 to 4 minutes, if the bleeding does not stop, then you know that you have to go in for your pulpectomy. So that's how you can use your radiographs as an effective tool to decide what the child is going to need and eventually prepare your armamentarium otherwise. Now, your tips and tricks for obturation. Make sure that you have an adequate coronal flare. What we use is endoflare by Micromega. So what we do over here is your white apex tip, usually don't try to engage it. So you don't have to reach until the apex. Even if you're in the coronal third of your preparation, of your root canal preparation, make sure that as you are pulling the syringe out, you are leaving some excess material along the line angles. And leave only that much excess material that you want to fill the remaining volume of the prepared canal in the apical third. So that when you push or you put some cotton pressure pack onto that excess white apex, you don't have excess white apex flowing out of the apical terminus. But the most important takeaway should be to try and keep your obturations short. The apical terminus in a primary molar is always in an ever dynamic stage. So make sure that your fillings or your root canal fillings are always short by 1 to 2 millimeters. Your tips and tricks for anterior preparations, what we do is we only use a broach or a H file to try and extirpate the pulp in toto. Only if required. Try to irrigate with sodium hypochlorite. And if you see that there is no bleeding from the canals, you can directly go and obturate without any preparations, but only in a vital case. And that's how you will achieve your fillings. This was done without any root canal preparation. So how do you achieve such near perfect fills is only when you will start respecting the ever dynamic apical terminus. That's when the apical terminus will affect. So we use an endomotor integrated with an apex locator, and we try to be 5 to 1 millimeter short of the apical terminus. So let's look at a single visit pulpectomy and the workflow for the same. So that's the protocol that we follow. But with our understanding of MIPD and selective caries removal, we have seen a rapid decline in the amount of pulpectomies that we do at our centers in Pune and Greater Noida now. We have tried to be more conservative at the tooth level and as well as the pulpal level. So now that we all are camera dentists, you will realize the importance of topical fluoride varnishes. A lot of reading material can be found on the website. That's the ABD manual. What we use is pro-fluoride varnish, which is by Voco. It comes in a variety of flavors, and children are more acceptable of the same. Now, this is an essential tool to instill a positive dental attitude, and children love to pick and choose which flavor of the topical fluoride varnish they want. So parents, some of the parents are really diligent enough who keep coming for their topical fluoride varnishes depending on their risk assessment, either every 3 months or every 6 months. So let's look at a clinical scenario, which was a high caries risk and for a non-compliant child. So this was a child who came to us at the age of 18 months. You can see that the root canal thickness, that is the dentinal wall thickness, there is hardly any secondary dentine deposition. You see active decay over here. You see a lot of white patches. What we did over here was we took care of the risk factors. We stopped the bottle feed that the parents were doing for the child at night. The ad libitum breastfeeding was also taken care of. We started with the intensive fluoride regimen, that is 4 to 5 applications in the first month, then eventually 1 application every month. And as we saw the involvement of the parents improving, we shifted to 3 monthly applications. And you can see that the pulp has remained vital. We can see that the dentinal wall thickness has also improved. And this is what we talk about being minimally invasive in your approach and maximally effective. So now if the parent or the child at the age of 4 wishes to have any aesthetic crowns, we can do it, but we have left it in situ. We have not done any restorative work after this. So although general anesthesia falls last into the behavior management or the continuum of behavior guidance, it is an important tool in our kitty. It is useful for children who are pre-cooperative, who have 14 out of children with SECC who have about 14 out of 20 teeth that needs attention. You have a failed nitrous oxide oxygen inhalation sedation or your oral sedation visit that has failed. And these are certain cases, your children with special health needs who need that extra bit of care in the OR, and that's where your general anesthesia comes into practice. And of course, it has a lot of benefits galore in the sense that you're able to deliver more. It instills a positive dental attitude. The oral health quality related quality of life also improves for the child. And eventually, because the child has not undergone any negative dental experience, the child does not have any memory of the visit. The child keeps coming for the preventive checks. And the procedures usually last between 2.5 to 3 hours for us in the OR. And we have to try and be definitive, as in for certain cases which you would have managed chair side, if you would have chosen restorations in those cases, you would probably want to go a step ahead and place a stainless steel crown in those kids when you're treating them under general anesthesia. So that's the operating room workflow. That's the operating room armamentarium layout. And let's look at a 2.9-year-old being managed in a span of 3 hours. The score was 16 teeth out of 20 that needed attention. And that's how quality dental care we can provide under general anesthesia. This is that similar case where we had done direct pulp capping. And let's look at the survival rate of what we had done in the OR. So this is almost a 30 months follow-up. You can see the zirconium crowns doing well. You can see the healthy gingiva. And all this not just happens because you were able to deliver quality care. It also happens because parents are equally motivated to come back for their preventive checks. And that's the 30-month follow-up, radiographic follow-up, all pulpotomies and the vital zirconias doing well for the child. Another child, 3.3-year-old, traveling all the way from Shriram to us. You can see the child was not eating anything. The child had lost almost 1 kg. The hemoglobin had dropped down to 9.2. The vertical dimension, you can see there was a loss. We had to actually prepare the mouth under IV sedation first. And then finally, we did the entire process of rehabilitation under general anesthesia. And let's look at the survival rate of the procedure done under general anesthesia after 14 months. It's been almost 3 to 6 months more of lockdown. So you can easily say it's almost 18 months now and all doing good. And that's being minimally invasive for the lower anteriors, wherein we have done only SDF application with Dr. Sanchit will be touching base upon. Another case that we'll quickly run through. This was a case with almost 4 years of follow-up, treated under general anesthesia, a lot of zirconium crowns placed in the anteriors and the posteriors alike. We tried to salvage the strategically important tooth. And that's almost a 2-year follow-up that we have. This is a 36-month follow-up wherein the strategically important second primary molar eventually gave in, but the first permanent molar had erupted, so we shifted to a reverse band and loop space maintainer, and that's the 48-month follow-up. And all of this happens with motivated parents. So a lot of practitioners, general dental practitioners who are colleagues, who are placing crowns in their practices for children, this is one technique to look for, because this is one technique where you actually don't have to use or open or lift your aerotor. So this is a technique which falls into the category of the much hype, the aerosol-free pediatric dental procedures. So what exactly is this? So let's look at this tip number 7.5. If this cavity is going to remain open, there's always going to be a lot of food lodgement. The bacteria are going to keep multiplying. They have their daily.
I'm extremely sorry, Abhishek sir. I'm objecting you.
Yes.
Can you please check whether the screen sharing is on right now? There are some comments that the screen is locked at one place, so they aren't able to see the slides. Please check.
Okay, I'll just check on that.
Yeah.
I'll just share it again, sir.
Yeah, please.
And you could just intimate me because I cannot go on Facebook to just check onto that. Is this okay now, sir?
It's okay. Yeah, it's okay on Zoom right now.
Yeah, I think we can see it now. Let's see it's on Facebook also.
Yeah, it's okay on Facebook also. Yeah, we can go. Good to go.
So can I start from the current slide only, sir?
I go back few slides.
Yeah, just quickly go through that few slides.
So the Hall technique basically falls into the aerosol-free pediatric dental procedure. So just look at this clinical scenario where in 7.5 an ICT.
Can you put a presentation view? It's in the slide view, I think. Just put it as a presentation view. Yeah. No, we can't see the screen now.
Just a moment. I think it just stopped.
Yeah, sure.
Yeah, is this okay now?
No, I think it's still in the screen. It's not in the presenter mode. Am I right, Dr. Swapnil and Dr. Ashwini? I think it's coming in the next slide mode. Can you try putting a full slide mode, Dr. Abhishek?
Is this okay?
So then we can't see the
is just
screen.
Automatically stopping now.
Okay. Try if you once again if you can. Earlier it was doing fine.
Okay, just a moment.
Sure.
Is this okay now?
Yeah. Good.
Yeah,
okay.
That's all.
Yeah, go ahead, please.
Yeah. So we all know that dental caries is a biofilm driven disease. So now if this cavity remains open, there is enough nutrients for the bacteria to survive and progress. But the moment you cover it with a crown and there is lack of oxygen supply, there is lack of nutrient supply to the bacteria, which could probably be still thriving. But the moment the source of nutrition is cut, and this is the basic concept on which the Hall's technique is based upon. So this was developed by Norna Hall, and you get up to the success rate is around 97 to 99%, provided your case selection is right. We will look into how to do the right case selection for the Hall's technique. So this is what we all need to know about Hall's technique. It basically decreases the karyogenicity of the biofilm by providing 100% good peripheral seal, limiting the supply of karyogenic diet and oxygen, thereby slowing down or arresting the process underneath the crown. So which are the cases where you wish to use? The most important being any ICTAS 5 or 6 lesion, more importantly, the proximal lesions, but always make sure that you see a clear band of dentine between the advancing front of the lesion and the front and the pulp horn. What are the armamentarium that you require? You need your orthodontic elastic separators in case of tight contacts. You need a sharp spoon-shaped excavator. You need a topical jelly or your anesthesia by your side. Uh, your sectional tray on your putty impression making, that is optional. That will probably help you in crown selection. And in case you wish, at times the separators may sit some gingivally and you may not achieve the desired separation. Then in those cases, you may need a TC26 tapered fissured burr. So let's look at the clinical protocol. If you see on the figure to the left, there is almost a millimeter of clear band of dentine. You have read that well. You have placed your elastic separators. Try to remove your elastic separators within 24 to 48 hours. Now, because of the elastic separators, there's going to be slight traction that is going to happen. So the child sometimes feels pain. So you may have to inform the parents to introduce the analgesics for the child. Make sure that when the crown is seated, that the occlusogingival dimension is also taken care of, because at times then the cervical region remains open, and that will be the region where your secondary cavities may form. So if you see over here in the fourth image, D5 was slightly short of going subgingival. That's when we shifted to D6 by after adequately crimping the D6 crown. So the immediate treatment outcome, what happens when you place a Hall's crown without doing any occlusal reduction? There is obviously going to be an increase in the occlusal vertical dimension, which most of the studies claim, which eventually settles down within 2 to 3 weeks time. It's going to instill a positive dental attitude, because you will realize that we were able to do 2 crowns in the same visit within a span of just 10 minutes. It helps avoid any invasive dental procedures requiring inhalation sedation or your advanced sedation procedures. So what is it that we need to look at follow-ups is no clinical signs of failure. Your major failures that you will eventually see radiographically will be the focal radiolucency or the child landing up with a dentoalveolar abscess. And we'll quickly look into some case scenarios. So if you see over here, open carious lesions, however, a clear band of dentine, which was seen in 7.4 and 8.4. We did something called as a SMART Halls, that is SDF modified traumatic treatment. We selected both the crowns in the same visit, and we luted the crowns in place. This is how the elastic separation, and that's the amount of separation that you will achieve eventually after 24 to 48 hours. And that's how the dentoalveolar compensation occurs over a period of 2 to 3 weeks. So you see that open bite that happens eventually taken care of. And the most probable reason that the authors claim is majorly through intrusion of the crown tooth and some amount of intrusion that happens in the opposing tooth. Your occlusion settling for another case within a span of 3 weeks. Now, if you see this radiograph over here, you see that clear band of dentine. And even in the radiograph over here, if you see, there is a clear band of dentine between the advancing front of the lesion and the pulp horn. So these are classical cases which will give you that success rate of 98 to 99% for your Hall's crown. I will show you my own failure, wherein we did a Hall's crown 2 years back because of limited understanding, or probably you can say overzealous. This was a case where you don't see a clear band of dentine. And we went and did the Halls after discussing with the parents, of course. And now you can see, although clinically the child is fine, but radiographically it's a failure. And Dr. Rikuchi clearly gives an explanation to this, that the bacteria which are in the depth of the lesion, they're basically asaccharolytic. That is, they can thrive or survive without any sucrose. And they are anaerobic, so they can thrive without any oxygen supply also. So they basically thrive on the dentinal fluid, and eventually the caries lesion progresses even after placing a crown. So these are few follow-ups that we have. Let's quickly look at a video of how the Hall's crown is being done. Coming to the most important PPA amidst the COVID-19 times, we also had a journey. What used to be dam for us is always a dam now. Now, what we need to look at, we all know about this new normal. And we all know that our understanding about the novel coronavirus is improving with each passing day. And we are seeing a lot of submissions towards the same. And what worries us, if you see over here, that only 51% of the children with the SARS-CoV-2 infection presented with fever and symptoms. So what about the remaining 50% that you're seeing at your center? They are probably the asymptomatic carriers. And if you see the following study, wherein children who were less than 5 years, we basically see children between the age of 3 to 5, they were the ones who carried the highest amount of the viral RNA in the nasopharynx. And if you see your rubber dam is an effective barrier between yourself and the nasopharynx. And a lot of studies that have already been done, and the infectivity of the aerosol is what we need to look at once the rubber dam has been placed. So there were studies which quoted that there was almost 98.9.8% bacterial reduction at 1 meter distance once the rubber dam was used in children. So what is it that is actually holding us into the use of rubber dam? What are the mental blocks that we have? The most important being that probably we are not confident about placing it. We feel that the child may not accept it. We feel that it's time consuming, but trust me, with due practice, you will be able to place a split dam for a child to finish a quadrant within a span of say 30 to 40 seconds. And there are a lot of studies to back it. This particular study, which was published in IGPD, which says that isolation with rubber dam caused less stress in children compared to relative isolation with cotton rolls. These are the commonly used clamps, and the most commonly used technique is the quadrant isolation. And that's how we punch the seam following the contour or the diameter change that happens. That is, it is wider distally and it tapers nasally. So that's how you need to punch your rubber dam sheets for a split dam. And that's how well the child also accepts it. And you are able to give quality dental care, not just chair side, but also under general anesthesia, where a complete arch isolation will eventually save at least 20 to 30 minutes of your time in the OR. So Dr. Sanchit and me both feel that we don't see any reason why the dam cannot be used in children. We are so overzealous now that there was a time when we did not have a rubber dam sheet and we ended up using a latex glove as a rubber dam sheet. Coming to J juvenile orthodontics, in tandem with your orthodontist, try to catch them early, catch them young, so that the eventual burden of care in adolescence is less. So let's look at early correction of anterior crossbites. Let's look at a clinical case scenario wherein we managed a crossbite case, which was because of the over-retained primary teeth. We got rid of them. There was spontaneous movement that happened. However, that did not correct the crossbite. You can see what we did next was a 2x4 appliance, and you can see that the crossbite was eventually corrected and the arch length maintained. This was a case of a single tooth crossbite treated with, again, 2x4 appliance. We raised the bite and we stabilized it with a cross arch wire. You can do your rapid maxillary expansions after due analysis and in tandem with your orthodontist. And these has expanders are specific because we are taking anchorage from the primary molars and the primary canines rather than the permanent molars. So this was one particular case wherein the child had anterior crossbite, which eventually got corrected with the Haas expander. And now you can see that the laterals which were rotated, they have derotated and have come in line into the arch. Now, coming to K, your kids-friendly operatory, we would strongly suggest all those practitioners with multiple chair practices to kindly leave a dedicated space for children. It has a tremendous impact in behavior shaping for the child. Try to use child-friendly colors, those bright colors, which could be your yellow, orange, your light blues, your pinks. It has an impact. There are studies which prove that it eventually your attire, your friendly attire instead of the white cloak that which you would be wearing. Try to avoid wearing that in your practices when you're seeing children. This is what we have in our practices where waiting is also fun. We have a lot of fancy gadgets. We have PlayStations, we have building blocks, we have a lot of games to engage the child in the play area. We have this operatory which eventually converts a child who is probably an FR2 to FR3, and he probably agrees to allow us a dental checkup or treatment while watching Chota Bheem. That's our recovery room. This is the reception at Greater Noida at my colleague's center, Tooth Tales. This is their waiting area. They've just shifted to a larger space. And this is the toothbrush station that they have now, wherein you can actually inculcate a good oral hygiene practices. The wall of fame, wherein you click pictures with children, you hang their pictures over there so that at follow-ups when they come, they are motivated. They have theme-based operatories over there. It's very interesting that they have aqua rooms with the ceiling-based TV and audiovisual aids at their advantage. This is the jungle room that they have. So all of this has eventually a positive dental impact. Now coming to lasers, lasers also has a wide variety of applications in pediatric dentistry. And there are a lot of evidence-based papers that have already been published. Most commonly, we are using lasers for tongue tie correction, high frenal attachments. We have done tongue tie corrections for infants as early as a 15-day-old child where failure to thrive, child is unable to latch, and we've taken care of with lasers. That's a case that was done recently by my colleague, Dr. Agarwal. So if you see, the healing is better. It is a bloodless surgery, and eventually the acceptance and the pain and the results are beautiful. That was a case of excision of fibroma using lasers, and we all went on to publish all this data. This was a case wherein we did a maxillary labial frenectomy followed by 2x4 appliances. Another case where the 1-1 was not able to erupt. We did some lancing with a diode laser. That's immediate post-op, and within 24 hours the tooth had already erupted, and that's the photo for post-op for 1 week. Lasers can be used for your coronal pulp amputation, your hemostasis, your disinfection, followed by your MTA, followed by your stainless steel crown, with favorable results even at 6 months of follow-up. And we already saw how lasers can be used for disinfection. Now, some of the practitioners may consider what's the role of magnification in pediatric dentistry? What's the use of these fancy gadgets? But we beg to differ over here, and we would like to reiterate that it's a must-have tool while we wish to deliver quality dental care. And let's look at a few cases. And if you see over here that in pediatric dentistry, you see the lowest number of them actually using dental loops. And that's the sad truth, that very few pediatric dentists are routinely using it. And the reasons cited are even more funnier, that they probably see well enough without the magnification. But trust me, once you have it in practice, you cannot do without it. So what we have is a 2.5x Carl Zeiss, because you are able to find your MB2s in your primary first molars, your primary second molars. Magnification is going to help detect those carious pulpal exposures. Now you've gone in with your selective caries removal, and you know that you are close to the pulp. If you go and pack glass ionomas over there, and you probably haven't checked whether there is an inadvertent pulpal exposure or not, and if you have checked with your magnification by your side, you would probably opt for a bioceramic first, followed by your glass ionoma restoration. Magnification is also going to help respect the surrounding tissues when you go in for your crown cuttings. You see there's hardly any peripheral soft tissue damage. In this case, we were able to retrieve the broken file fragment with the help of the loops, and we were able to obturate all the 4 canals. Magnification is eventually improve your quality of work. It's going to help repair these failed composite restorations, which were done under general anesthesia, which we eventually managed chairside under nitrous oxide oxygen inhalation sedation. And that's how magnification really helps. It also helps analyze why sealants with porosity fails. And we eventually went and did a PRR for that particular tooth. So let me hand you to my dear friend, Dr. Sanchit Paul, who will be taking you through the second half of the presentation. Sanchit, could you start sharing your presentation
screen? Yeah. So we are just exactly 1 hour into the presentation. We might be running few minutes late because of some interruption between. So guys, I know it would be late to finish probably because we might still have an hour to go. But I hope we are keeping you interesting till this half of the alphabetical journey. And we would be hoping to have you around till the end of the journey. So let me take over from the letter N now. So when we talk about letter N, the first thing comes in the mind is the nitrous oxide inhalation sedation. You ask any pediatric dentist, I think this is the hottest topic for each one of us. And I'm sure now more and more general practitioners are getting aware about it. So where it is comes in the picture. So when we talk about a child, in particular, in a more layman way, it always comes in the form of, oh, maybe the child might be fearful, or maybe the anxiety. Now, clinically, both of them are indistinguishable. And what we generally find is a child who's finding it tough to really accept the things. But let's look at the same expressions through a video, that how it was before nitrous oxide sedation. And although the child is being wrapped around in a Pepu's board, or what we call as a pedo wrap, but still it's not the best and psychologically positive way to manage a child. In today's time, we can proudly say that now we have moved over from managing a child under a wrap or a blanket, managing a child which is FR2, FR3, or in a more simpler language, a child who's finding it tough to cope with all the exposure in a more refined way. I hope we can listen to the video, the audio sound.
You need to share your computer sound.
Yeah, the audio is
audible now. Basically, we all have seen this and we all have gone through it. But the moment when you start using nitrous oxide like magic, especially if it is in combination with an amazing pharmacological management technique. So alone, nitrous oxide gas will not make things happen. We always need to involve our basic flavor management techniques in the form of test-to-do, in the form of voice modulation, in the form of modeling, desensitization, and most important, the TLC, the tender love and care. Together, all of them leads to a good outcome where we are able to do the desired treatment in a more pleasant way, and the child and the parent both go with a feeling of, wow, this was fantastic. Now we can safely say that certain children actually react like this after getting an LO shot. There's a 6-year-old girl who was actually doing a Kathak dance after getting LO shot, and trust me, the expression on the face was, on the parent's face, was nothing like a miracle. It's an amazing practice builder for the simple reason because no parent wants the child to actually get into that frenzy mode of crying and howling. Only the people who understand and do nitrous oxide know the magic in it. So let's quickly understand where all we can use it. Now the general conception is this: there's a child who's not cooperating otherwise, we should use nitrous oxide. No, that's not entirely the right way of approaching it. Nitrous oxide inhalation sedation will only work for those children who are potentially cooperative but are anxious, apprehensive, and a bit of tentative, partly because of previous dental experience or partly because there is generalized anxiety. Now that doesn't substitute for the children who are not ready to accept the mask or who requires too much of volume of work and it is beyond their capability to accept it. That's the reason nitrous oxide inhalation sedation is a part of the sedation continuum where other sedations like oral sedation, deep sedation, or general anesthesia exist. So our sincere advice to the group and to this esteemed platform is that once we are thorough with this part of sedation continuum, then we are more equipped to know where we have to use a nitrous oxide or an oral sedation. But what are the goals of this sedation? Major goals are that we want to provide the high standard, uncompromised quality care. The moment when we think about pediatric dentistry, the first thing comes in the mind is, oh, only GICs and okay, whatever I can do because eventually the teeth will go up. And that's not the best way. And what Dr. ABHISHEK and we together believe that temporary teeth should have permanent solutions, not something which requires again treatment again and again. Also, we wish to minimize extremes of the disruptive behavior. There is no fun of doing one tooth in one visit and the child many other things. So it's important that the positive behavior should be encouraged and the negative behavior should be discouraged. So the positive psychological response, the overall child welfare safety, and most importantly, we don't want to have the adults which are fearful of dentistry. So that is one thing we should be always keeping in mind whenever we are trying to do any treatment to any of the child. Now, what distinct advantages nitrous oxide have? It has the best thing is it has a flexible duration of action. It will work only till the child is breathing, nothing more or nothing before that. The best part is it has a very rapid onset of action. Within 3 to 5 minutes, its action start working. And the moment the child stops breathing the gas or we switch over to nitrous oxygen, there is a complete recovery within 5 to 7 minutes. Now we can safely say this thing is not possible in any of the pharmacological drugs which we use, or for that matter, anybody use. And also in this drug also we can actually titrate. So wherever we feel that we need to give more stimulus in the form of extractions, crowns, or something which requires more invasive treatment, we can go to a higher level, or we can go to a lower level where we feel the child can accept it. It is not only analgesic, but it is also mildly amnesic. It has almost no allergy. And one of the things which is always in our mind, which is weighing down, that is it safe? So let me put it on this platform in a very clear and sound way. It has a nitrous oxide alone has a clean record of 150 years of no mortality when used as a single agent. Yes, we can use in combination with other agents too, but for that we need a better skills, expertise, and understanding. Alone nitrous oxide can be used by any of the dentists all over the world. Now, there are specific guidelines available all over the literature. This is AAPD guidelines in 2013, and it clearly mentions what are the protocols to follow in the form of documentation and in the form of carrying out the procedure. Now, both Dr. Abhishek and me have been doing this centralized nitrous sedation for quite a bit of time now, and we feel that it has substantially reduced any number of the cases which we used to do in the operatory. So that has been a very, very good positive change. Our journey has been more than 10 years long now. Dr. Namini sir has been the one who actually introduced this gas back in 2011. And through Manipal, through Sick Kids, through Toronto, and now in Greater Noida and Pune, we are trying to use this every day. We laughingly say that this gas is not a Mercedes which we have to bring out only rarely. This machine and this gas should be used on an everyday basis, especially not only as a last resort, but also to make sure that it can be used as a behavior management tool. We call it as a happy gas effect, and that's how we try to do the sedation documentation. And it's very important to cover it medico-legally, so make sure that we have a good idea about it. So although we have hundreds of videos on this, I think this one video will suffice what all we want to talk about nitrous oxide inhalation sedation or noise. So this is something which we usually see in our practices, our waiting area, where the moment the temper tantrum, stubbornness, resistance, the resistance comes out. So that's where we have to see how we conventionally approach it and how it's going to be under the noise. Once the mask is accepted, the hand over the mouth and the involuntary reaction of resistance goes off. Now the child is feeling distant, and now this is where your action comes on cycling the breath and reaching to the level where the child starts responding for next letter, which is O. Now, O for our pediatric dentist, or for in this contemporary pediatric dentistry, stands for oral sedation. I'm sure most of us have heard about pedicloral or ticulifos, which is a more widely used drug, which one like to use in more day-to-day cases. It comes in the medication with the packet dosing of 500 milligram per 5 ml, and the prescribed pediatric dosing is 50 to 70 milligram per kg, 60 to 90 minutes before the appointment, and preferably ASA1 child. So when we say ASA1, in which there is no medical comorbidity or anything which might require more intensive monitoring. So this is fairly okay, but in our experiences, it has its own limitations, because the moment the child is a little big enough to resist, it doesn't work the same way. All the literature says it can work together in simultaneous with nitrous oxide. But our personal favorite, as per the science, as per the literature, and as per clinical experience, has been midazolam hydrochloride injection. Unfortunately, the oral syrup is not being manufactured or being promoted in India as of now. So more of midazolam hydrochloride IV injections are available, which comes in the formulation of either 1 milligram per 1 ml or 5 milligram per 1 ml. Now, the prescribed dosing for the same is 0.5 milligram per kg, 15 to 30 minutes orally before appointment, again in ASA1 child, and gives minimal to moderate sedation. Now, from this platform, we are not trying to promote that one can use any drug without any prior reading or knowledge. But what we say is, once we know about the pharmacology and basics about drug, this is something which is safe to use chairside without any anesthetist by side once you have your learning curve. Now, midazolam is basically a benzodiazepine, which we all know, which is amazingly good for the kids because it has a high metabolic clearance and a quick rate of elimination, which simply means it quickly starts and within no span of time, its effects goes away. So we are not looking for a daycare procedure where the child has to be there for 3-4 hours. And not only it acts as a sedative, it also has a hypnotic effect, anxiolytic effect, mild amnesic, and also can be used as an anticonvulsant agent. Again, the guidelines are the most important thing. Anything is safe if we follow the proper protocol. That's why the guidelines have to be followed, and proper sedation documentation record should be there, which covers not only medical legally, but also make sure that we are always on the safe side of the sedation. Now, we can talk more and more about it, but I think the best part about this presentation should be more of clinically oriented. So we would like to show you a couple of videos of how this drug changes the child's behavior and overall outcome. All the kids, because the child might have much more complex. One is towards dilution, which is from the eating agent, which can be a source for the honey or
Excuse me, sir, I'm objecting.
and assisted by the parents. It is very important that all parents, child, and all the
Excuse me. Ultimate outcome is not only the treatment, but also to make sure that both the parent and children are positive after the treatment. Now let's watch another quick video of how to go about for this oral sedation procedure.
to the next letter of P, which is Pitt and Fisher sealants. Now, this P again, Pitt and Fisher sealants is almost synonymous with pediatric dentistry, but through this esteemed platform, we would like to highlight that it's not only for pediatric dentistry, it's actually for everyone else. But let's quickly review the sealant material. So we have basically broadly two types of materials, which we all know and aware of in the form of resin-based sealants or glass ionomer-based sealants. Now, resin-based sealants can be again filled or unfilled, can be transparent or opaque, and can be cured by ultraviolet light, by autopolymerizing, or maybe by a light curing. But it's very important to also understand that not only the resin-based sealants, but a glass ionomer sealant is equally and importantly effective, especially when we're talking about high caries risk children. Now, when we look at the literature, the Pitt and Fisher sealants looks like a pretty straightforward option, but it again always requires optimum isolation, proper cleaning of the tooth surface, maybe with a plaster or with a prophy pumice, a proper etching and bonding protocol, and then putting a sealant. So it's a clinically technique-sensitive procedure, but what the literature says that it actually decreases the caries increment from 40% to almost negligible to 6%. So a Pitt and Fisher sealant is indicated for all those teeth, especially the molars, the permanent molars or the primary molars, where there's another caries activity going elsewhere in the mouth. Now, when we compare the sealants to other preventive strategies like fluoride varnish or SDF, what we have found is that it is much better than putting no sealant or putting only fluoride varnish. So through this platform, what we want to highlight is that Pitt and Fisher sealant should be the mainstay of any preventive strategies in the mouth where the other teeth have caries or decay progress, and also we have some other teeth which are still not stained or affected. Now, some literature has started highlighting that as we mentioned, the low and medium viscosity glass ionomers, which is your either a glass ionomer based sealant or your resin modified GIC or your conventional type 2 GICs, can act as an equally good Pitt and Fisher sealant if we compare to the resin sealants over there. The advantage of these sealants are even if these sealants actually left behind or they are dislodged, there would be still some fluoride which is releasing, which would be actually protected to that tooth surface compared to the resin sealant only. Now, one of the interesting study of BMC Oral Health 2014 highlighted that if the caries progression is only in the outer half of the dentine and it is cavitated or very minimally cavitated, we actually don't need to remove any of the caries tissue and can actually use only a resin-based or a GIC-based sealant in comparison to trying to treat the tooth with a composite resin restoration. So that is something which is a very interesting takeaway probably from this presentation about the sealant. Now, as we mentioned, the sealant has a proper protocol of cleaning the tooth properly, doing the etching and bonding protocol, and then putting the sealant. And although the market is full with various type of sealants from 3M, from Ivoclar, and different companies, our personal favorite has been Boco Fisher X for the simple reason that it has an amazing consistency and non-tripping technology, which makes sure that there are minimal bubbles and a very good flow. We also like to use Fisherotomy burrs from SS White, which really makes sure that we have enough depth for the sealant to stay, but we are not doing any tissue removal to place the sealant. The sealant and resin restorations are almost simultaneous and permanently. Again, preventive resin restoration basically means a combination of a restoration of a composite or a GIC, and over that we can put a sealant over there. And again, in a child or in a child with a mixed dentition, when the primary molars are already infected, we would always suggest that first thing we should do, rather than treating the molars, primary molars, is to actually seal the first permanent molar, because that is the best service we can give to the child in terms of prevention. So this is a beautiful picture series by my good friend Dr. ABHISHEK, who has highlighted that how exactly the fissures are there in a permanent molar, but which is not visible to the parents or us unless until we really clean it. So we would really highlight and suggest to use something called Triplaque IT gel. I'm sure some of you must be using it already, to basically highlight the old plaque, the new plaque, and the high risk plaque. So this only will give us a clear idea that what all we need to clean, and only once we clean that whole surface, occlusal surface, then only we can make out the initial signs of cavitation or the demineralization. Now, this is very, very important because unless until we clean the surface, no matter what sealant we are using, it's going to fail eventually because there's a biofilm which is adhering to the grooves and which is going to fail that bonding of the sealant to that groove. Now, only once we use a good trophy pumice or a surface blasted asterisks, then only we can see these small initial lesions, which can be managed by a combination of restoration and sealant, as we mentioned. And most importantly, they are self-cleansing. So as we have highlighted, pit and fissure sealants are not supposed to be only for kids. It's not only supposed to be for permanent molars. Primary molars, permanent molars, be it a 5-year-old or be a 50-year-old. Sealants are the best thing one can do for any of the tooth, especially when you are trying to do a root canal treatment in 6s and your 5s and other teeth, and your 7s are still there. The best service when we can give is to seal them so that they don't come back for the root canal treatment. And trust us, preventive treatment will give you much more in the form of satisfaction and gratification and probably revenue, rather than trying to practice more of invasive dentistry. Coming to the next letter in the form of Q, we want, this is something which is always a tricky letter, but I think the questionnaire really fits it well. Now, when we talk about questionnaire, we all have our consent forms, our registration form, which is not only cumbersome for the parents to fill, which also doesn't give you the entire information. Now, recently we have tried to put all this together in a Google form, which is also the need of the hour because of the COVID pandemic time. So this electronic registration form not only gives us the information in the form of demography, the details, also gives us the idea about how would you describe to personality of the child. So these are all important things because when we are trying to treat kids, it's very important that we know what type of kid his personality is and how the parent describe them, and accordingly we can coordinate and apply our behavior management strategies. Now, again, the medical history, the reason for the visit, and since as an exclusive criteria dentist and otherwise, we should not only focus on drilling and filling or the cavities for the children. So we would like to see on the airway orthodontics part in the form of mouth breathing, snoring, drooling of saliva, any speech problems, nail biting. So this will come only in the picture when you ask the question, or it should be in your questionnaire. So these questionnaires are designed, if you see the questions, not on a direct yes and no form. It's basically designed on the motivational interviewing form, where we are asking the parent that, do you think that you should be seeing that brushing on, or you are fine that the child is brushing on its own? Because the rule of this questionnaire is that unless until the parents are motivated and understanding that what really makes a difference, no matter how much we try to counsel them, the change won't happen. Same goes for the child toothpaste and the dietary part over there. So again, these are the things which we can easily do on our own and send it across. Let the parent fill it at peace when they are at home. And once you have all the information, then you can positively motivate them for each and every criteria, what you feel is important. Now, today's time, we have lots of Practo, Google, Facebook, just dial feedback form over there, but nothing beats a conventional feedback form, which you can get the parents filled within the clinic premises. Again, good questionnaires and good feedback really helps you in building the practice and understanding where you can really improve. The whole idea about this questionnaire is that we try to ask too many questions, but or we are trying to ask too many, we're trying to answer too many things, but it's important to actually ask the right questions, because only the right questions will give you the right answer. So we are pretty much pro of motivational interviewing in dentistry. The rule is simple, that resist them telling what to do. I'm sure all of us have tried telling our patients, okay, you should do brushing twice a day. And I'm sure every one of us know that it is hardly being followed. So it's important to understand that what really motivates them. Like, for example, we don't ask the child, okay, do you do should brushing twice a day, or the parents say that, okay, he doesn't do brushing twice a day. Instead, we ask the parent that, do you do brush twice a day? Because unless until you brush twice a day and you do the night brushing, the child will never follow the example. Same way, it's very important now. I'm sure what makes a difference between a good practitioner and a great practitioner is listening. So listening with empathy, will give us an idea that what exactly are the barriers from the parental point of view or from the patient point of view. And only those barriers we need to empower and actually motivate them. So you can read more about motivation interviewing. It's a very hot topic among academicians and the research people. And it really changes the game in the form of if you want to bring the change. And there are a lot of knowledge and attitude and practices studies regarding the same. So we would be happy if you want to go and on PubMed and read about more about it and implement into your practice. Coming to the next letter, which is R. Nothing beats a good record keeping and documentation in the practice, and that's what we want to highlight with this letter. Now, no matter how much we accept or stay in denial, but the fact is that most of us have been very inadequate in record keeping, especially the people who are busy and seeing a lot of patients every day. Now, although I personally feel that there has been a tremendous change in the last few years, especially because of all the software which has come, and Practo has been there for a while, but we are not still sure how many people are actually using Practo for all the documentation in the form of writing all the notes, doing all the invoices, billing, making sure all the pictures, x-rays, radiographs, and all the important stuff is at one place. So again, as we mentioned, there are guidelines for the record keeping. And it's not only the first visit where we have to do the record keeping. Every visit, how much LA we are giving, what was the child's behavior, what was the parental behavior, what was the important thing, the red flag, the cartoon that parents like, what worked for the child, what doesn't work for the child, how much nitrous oxide, every single thing has to be documented. And it's just a matter of time when all these Clinical Establishment Act is coming and NABH guidelines are coming, e-health records, what we call as EHR, will become mandatory. So before it becomes mandatory, let's get used to it and implement it to our practices. So again, an informed consent form is an important part. All the record keeping in the form of giving instructions before, after, doing the sedation record, as we have already seen, consent forms. It's important to have paperwork, although you can make it all digital by scanning it or again putting it in the Google form. But whatever it is, it's important to maintain the records. It's an amazing practice builder if a patient comes after 5 years, 7 years, and you tell them, you know what, I have all the records, what I have done 7 years back. And a very important takeaway, it cuts out the lot of story making which happens because as we all know, and as Dr. House MD says, patients always lie or patient always makes it up. So if you have records, you will know what you have done and you will not be overwhelmed while if something goes wrong afterwards and the parents are trying to or patient try to say something else. Now, we all have been trying to use different softwares for our appointment scheduling and part over there. And we have different software in the form of Librate, Best Assist, software part over there. So this is something which we personally use and it is our personally favorite for the majorly simple reason that it has a beautiful interface and small tabs give us everything in one page. But again, our idea is not only to put appointments. Thankfully, because of my training in Toronto for my special kids fellowship program, I'm actually now trained to write all these essays. Now, this essays contains not only the basic chief complaint and your the history of presenting illness, but also detail about diet, oral hygiene, your examination, each and everything, the soft tissues, the hard tissues, the radiograph, what was done, what was the parental attitude, what was the child attitude, what we have given. So again, this might be time consuming or cumbersome in the initial time, but eventually it will pay you off because once you have everything in your place, then even if the parent comes after a long time or if they misses anything, you have everything in place and it maintains the transparency between you and the patient, which is a very important pillar stone. Now again, we follow something called ICDS and ICCMS criteria, and each and every tooth is actually charted like an odontogram, where we not only plan what is a diagnosis, but we also plan what is the treatment to be done. I'm sure this lockdown and otherwise, we all are pretty much trained and exposed to the dental photography, the digital dental photography, be it a DSLR or be it a mobile. So I don't want to go into details into it because I think there are already experts who have talked in detail through this platform and otherwise. But what we highlight is, apart from a good camera and good thing, you should have one person who's trained to take good pictures, because not every time with pediatric dentistry and otherwise, you would be able to take all the pictures. So it's important for your staff to be trained, or maybe your colleague or spouse or your associate. And it's also important to have good photographic mirrors, because only good photographic mirrors can reflect back good pictures, which will eventually come handy in the documentation. And one simple example I can give is that whatever we can show this in this presentation is all because of the documentation we have tried to do in the last few years. Coming to the next letter, which is probably the most significant letter, the S. It's not only because my name initial is because of S, but it also has something which is the most, we would say, popular contemporary material, which we call as SDF, or what we can say is as a silver bullet. Now, SDF or silver diamond fluoride, if I can simply put it in, is a colorless, painless liquid which is put on a cavity or a carious lesion to arrest the decay. That's a plain, simple definition. We're always looking for a medicine, for a magical drug, but this is one thing which is coming close to it. Now, it is basically used for the children who are too young, cannot cope with too much of the treatment, the children with special needs. It delays the extensive procedure, invasive procedure, to do the same conventional drilling and filling, and obviously avoid any pharmacological invasive procedure in the form of sedation or G. Now, this has been a huge paradigm shift in our practices, and I'm sure every pediatric dentist attending this presentation would agree with it. And I'm sure now it is getting more popular in the general practitioner criteria also. Let's try to understand what exactly SDF is different from fluoride, which we regularly use. So as we know, fluoride role, we all have a pretty good idea about it, but the silver in the SDF, which is silver diamond fluoride, has bactericidal activities, and it kills the bacteria, and which promotes the decay and basically arrests the decay. Now, why to go for SDF technique? The simple reason is it is a biological driven option for the dental caries management, which is backed by optimum scientific data, provided the case selection criteria are good. The most important thing to understand here is it is not only acting as a caries region management where we are only treating that one particular tooth, but it also does caries management, which means the whole caries activity which is going in the child's mouth is actually subsided because of SDF. It is not only time bound, which because of that it instills a positive dental attitude. It is one of the simplest things which you can do for a child, or for that matter, anybody, any adult. It is simply a brush and a liquid which you have to just paint for and wait for a minute, and that's it, you're done. So it basically avoids the child's repetitive cycles of getting restoration done again and again, especially a very young child. And with SDF, we can safely say no to local anesthesia, or conventional tooth preparations, caries removal, and a prolonged dental appointments and restoration. So if you simply ask me where I can use this, it can be used in any child or adult for that matter, where the age, the anxiety, the behavior, or inaccessibility is an issue. Even a community health dentist or public health dentist who find it difficult that every rural population, especially the elderly, find it difficult to afford the dental care. It comes in a very, very economical part over there. Again, we are not saying that this should be a primary go-to the material, but if not anything else, at least we can use SDF to arrest the ongoing decay. So again, any caries lesion which is asymptomatic, which is not involving the pulp, which is progressing but not into the pulp, has a clear band of dentine, comes into indication. We should obviously not use in the cases where there are clear-cut signs and symptoms of irreversible pulpitis, maybe clinically or radiographically, teeth which are unrestorable, any allergies, although it's very rare, but in case somebody has a documented allergy, then avoid it. And also to avoid in those cases where there is active ulceration, any mucositis, or any desquamative gingivitis. Now, what all we need, actually we don't need much. We just simply need, after the consent, a simple 38% silver diamond fluoride, maybe a fluoride varnish, which is optional, some simple plastic dappen dish, not the glass one, a micro sponge brush, some Vaseline or petroleum jelly, and a cotton shield over there. In case we are doing proximal areas, we might need a SDF superfloss. And that's it. Nothing more than that. Again, SDF is a topic where we can speak for hours and hours, but just to keep it simple and easy, it can be used not only for pre-cooperative children who are the parents are refusing GA, or who can actually can't cope up with a lot of treatment. We can also use in children who are potentially cooperative, but we want to use as a MIPD, which is minimally invasive pediatric dentistry protocol. We can use with or without rubber dam. So primarily all those class 2s where we feel it's a minimal involvement only in the outer half of the dentine and without any pulpal involvement, rather than doing all those cumbersome class 2s in the young children or the children who can't cope up with too much of the treatment, we can use SDF. And again, it's a very, very amazing tool for using for the special needs children. So there's a proper protocol. Again, we would suggest you to go to the literature. There is a beautiful article by Dr. Yasmin Crystal in DCNA 2019, which highlights everything. We are also trying to publish our own literature on this, which would be out soon, in which we highlight that where to use as a smart technique or SDF modified ART. We all know atraumatic restorative treatment, but at today's time, it's basically smart material, which is SDF modified atraumatic restorative treatment, or we can use in a smooth surface. So again, we would like to showcase more cases about how to go for it. But what exactly we are aiming for? We are aiming for immediate treatment outcome in the form of caries arrest in the form of hard and shiny lesion with minimal or no sensitivity, which eventually leads to positive or minimal unpleasant dental experience and reduces invasive sedations or GA events in the children, and which is readily acceptable by the parents. What we can say from our anecdotal experiences that in the last 2-3 years, all those parents who were refusing GA or who were not comfortable or who has a lot of biases were readily accepting SDF, and at the end it benefited child, it benefited parents, and obviously we were happy to provide the care. It's better than doing nothing or doing something which is inadequate. The long-term treatment outcome obviously is the SDF provides a remineralization and promotes the reactive dentine formation. We also see something called zombie effect of the SDF, where we can see some residual staining on the other teeth surfaces in the same mouth. Again, this is a beautiful property which again manages the caries activity apart from the caries lesion. And with this, with the Hawes technique Dr. ABHISHEK highlighted, with minimal invasive pediatric dentistry options like GA or like SDF, what we are promoting and highlighting is minimally invasive pediatric dentistry with maximum effective caries control and longevity. Okay, so there are now some SDF available in India in the form of eSDF by one of our contemporaries who's manufacturing it. We also have options of Rivastar and Fagaman, which is Fagaman is an Argentinian product, and Rivastar is from SGI. But our personal favorite has been Advantage Arrest, which is from Elevate Oral Care USA. The reason is because it is the most researched, most patented, and most highlighted product all over the world. And it has an FDA approval for the breakthrough therapy status. Let's see quickly see some cases to highlight how does it work. So see, these are 18-month, 20-month children, and as you can see, even the second primary molars are not erupted yet. Now, those young children where we have seen the lesion, doing nothing is the biggest crime we can do. I can safely say that. And doing too much is also too invasive for the children because they are too young actually to be put under GA. Now, as we can see, the lesions are ICDS 04 or 05, which is not involving the pulp. But yes, we cannot leave it just like that and only varnish one surface. So for these lesions, for these children, and for these cases, SDF is nothing less than a magic or a big boon. We can say that. And a simple SDF application, palatally and labally, we can see it immediately arrests over there. So this case series of a SDF putting up in a toddler is a 12-month journey, which highlights that those lesions, which eventually could have deteriorated if we would have waited, was not only nicely arrested, but we can see that hard, shiny lesion, which makes sure. So for a non-SDF person or for somebody who don't know about SDF, this might look like a cavity or caries, and they might try to remove. But trust me, if you try to use an explorer and try to run over it, it is harder than your enamel because it is a combination of your fluorapatite and your hydroxyapatite. And this is not going to deteriorate. Yes, we can obviously mask the color because of the silver penetration by our conventional approaches of drilling and filling, strip crowns and zirconia. But again, the major role is that we have certainly avoided a more advanced deterioration in the form of root canal treatment and extraction. Now, SDF can be used also in proximal lesions. in this what we call as expanding floss way or super floss way. And as we mentioned, it just because you can place a rubber dam and you can place a crown, it doesn't mean that we really need to go and do all those tricky class 2s. As you can see in the radiograph, there is a lesion which is in the inside the dentine in the just outer half and completely approaching the enamel. Once you put an SDF, that lesion was stable for more than an year, and now it is still under the follow-up. And although there's a slight discretion which happens, but again, it's between the 2 teeth, which is hardly visible. So these are again minimally invasive pediatric dentistry ways where we don't have to do too much of the things to manage the things. And once the child learns to floss and parents can follow up, you would see amazing follow-up after 24 months, 36 months, and 48 months. So this is again an innovative way of using SDF as a pit and fissure sealant in a primary molar where other molars are actually getting deteriorated. Now, if you see in this case, we can see that we have to put a crown for 7-4. The 8-4 again has a lot of buccal demineralization, and there is activity going in 7-3, 8-3. Now, it's very, very imperative to see, to make sure that we seal the ease, which is going to be there for the longest possible time and has the chances to actually further deteriorate. So again, SDF can be used in innovative ways depending on how we look at it and how we want to go for it. So again, these are some examples where we have tried to use SDF as a smart technique or as a technique where we don't have to go for conventional drilling and filling. As Dr. ABHISHEK has highlighted, we have to be very selective with our caries removal technique. It's not important to remove all the brown, all the black. We have to stop at the right level, put in SDF and fill it either with a restoration or put a crown over it. So it's a little mind thing, which a learning curve, which we have to over the time get acquainted with it. That my aim is not to do too many things. My aim is to do things which is simpler for the parents and the children to accept. But this is just a small video to highlight how do we do SDF in a young children as a 6-handed dentistry position. Another video where we want to highlight that how the young children who are a bit combative can't really accept the procedure, but if we can do certain things to the children so that at least the caries progression doesn't continue and there is reduced erectional activity. So let's have a look at the video. Highlight to do a SDF in a preterm child who has not only very low birth weight but very reduced hemoglobin, and this child has very, very high caries risk in the form of full-blown CC, and this child with a 7 kg, 8 kg weight actually cannot be taken care anywhere, not any pharmacological approach. So SDF comes as a savior into it and really, really help in managing the caries risk and reducing the further deterioration. next letter, which is T. Now, T is again for the pediatric dentist or for probably all of us, basically means a trauma management quick tool. Again, this is a huge wide topic, and we don't want to go into the majorly the guidelines protocols over there. What we want to highlight over here is the moment a trauma comes to the clinic, be it a general dentist or be a specialist, this is something where we actually, it's an emergency and we really have to quickly do our best. And generally a pediatric dental trauma comes with a lot of baggage where the child is in distress, everybody is howling, the parents are shocked, they don't know what to do, and there's a usually chaos. What we would still suggest is that always have dental trauma guidelines available with you. These are from International Association of Dental Dermatology. Recently, 2020 guidelines have been published and available on internet. Now, always keep these guidelines handy with you. You can take a printout available, but there are also apps available. Always make sure that before you attempting, even if you remember and know everything, just refer these guidelines, because these are the guidelines which are not only evidence-based, but that they keep on updating. So this will always give you the most recent understanding of what to do in which scenario. And you can actually convey to the parent that I'm trying to follow the guideline which has been given and not try to do something which eventually will backfire us. Now, there are tools available, applications available in the form of dental trauma first aid, SOS and other applications. One can go to the Google Play Store and find it. We would also want to encourage from this platform that now we have our own Indian Society of Dental Dermatology, which is basically formulated from CDER AIMS, New Delhi. And each one of us, doesn't matter which specialty or general practitioner, should be part of this, because it's a matter of time when we get a trauma in our clinic, and then in that time, if we are not well equipped, then we might not be able to do good service to the patient. Now, it's also important that we don't have to always wait for the trauma to happen to give the thing. So to provide the treatment, we can always provide encouragement and provide knowledge about something called mouth guard. Now, mouth guards are something which is very important, especially for those children who are indulged in contact sports. Although these are COVID times and things are different now, but we always know the children who are involved in a lot of outdoor activities. Now, it's very important that you get to know that if the child or the parents are inclined toward this, and you can encourage them to use mouth guards, because mouth guard is one thing which not only will prevent the dental trauma, but a lot of other sequelae to it. So there are custom mouth guards available, the Boyle and White available, or one can easily get it prepared from the lab. There are so many labs available. But not only we are managing the teeth, we are also actually managing our TM joints and maybe a future migraines issue, TM joint issue, and TM mandibular disorders. Coming to the last few letters, we're just quickly finishing in the next 10 to 15 minutes. The UV stamp technique from the letter U is something which I think as a practitioner, you guys are most used to do it. What we would like to highlight is that as a pediatric dental practitioners, we can still attempt it, especially in those lesions where we see the occlusal anatomy is intact. And not only with composites, one can use UV stamp technique also with your conventional GICs or your highly dense, highly packable GIC in the form of Ecoforte film. Now, the technique is simple. I don't think so. We really need to elaborate on that. But basically, we can use a liquid dam or very unfilled resin over there and press it with the cut portion of the microsponge brush and quickly light cure it, get the stamp out, then do a restoration preparation, and then put that stamp with a layer of glycerine so that it doesn't stick, and then light cure it. So again, the aim is to get the anatomy in the best possible way and maintain it so that the overall outcome is always good rather than just doing a simple filling. I want to highlight the new UV thing, which is we are now more used to and more familiar, is the UV GI. Again, this is something which we are now all well aware. So just wanted to highlight another UV, which is with the letter U. Coming to the W letter. So white spot lesion management is something, again, which is more or less very frequent in our day-to-day practices. We all know that there are lesions which are non-cavitated. They are pretty opaque. They are not fluorotic. They are not amelogenesis imperfecta, but they are just that white spot lesions because of maybe a Turner's tooth, maybe a local enamel hypoplasia, maybe a molar incisor hypomineralization. But those lesions are the tricky ones because one cannot simply just drill and fill them. So one of the most advocated technique is called resin filtration. we are assuming that most of you are aware about this technique, and it is one of the most important non-invasive approach where we don't have to drill and fill and put any LA to it, and just keep it simple and mask that lesion by infiltrating the resin inside the and just matching the refractive index over there. So just highlighting a couple of cases where you can use not only for the permanent teeth, like as we can see in these teeth, these are permanent teeth which is affected in molar incisor hypomineralization, and with the correct protocol of using your phosphoric acid, your hydrochloric acid, then your icon dry and icon itch, icon dry and then icon infiltrate, we can get a very good outcome, which is not only plaque free and biofilm free, but also gives a very nice gloss and finish. We also want to highlight that a lot of times we see the primary canines are not broken, but they are demineralized and have that white spot lesions. Again, one can use resin filtration in those cases in trying to mask those white spot lesions and actually make them hard, shiny, and biofilm free over there. So this is something which has been working wonderfully. Dr. ABHISHEK does a lot of them, especially in the primary canines, and we really don't have to put crowns and doing fillings. See, fillings and restoration will never be the answer to the repetitive cycle which keeps on happening again and again. So it's important to do certain things which actually is not only natural, it is anatomic and gives you a much better outcome for long term over there. Okay, so this is a quick video which we probably want to just quickly show you that how the a white spot lesion in a primary tooth looks like. This is basically a demo video of how the resin filtration is done, and this actually is a step-by-step video. I wish we could have shown everything over there, but again we are time bound and we are already getting time out over there. But this is just showing the pubis clearing part, then using the icon edge and keeping it for a couple of minutes, and then using icon dry and then putting an infiltrate over there and then make it shiny and resin. One can repeat the cycle of icon etch and icon dry till we get the masking of the lesion, and then do the infiltration and cure. So you can see these videos on our YouTube channel. They're all available, but I wish I could have added more time to watch it. Quickly for the last 3 letters, the X is basically for X-ray unit. I think now most of us are equipped with portable X-rays. Gone are the days where we are only working with wall-mounted X-ray units, which we really can't travel and cannot take into emergency room. Maybe the OTs if you're treating the children under the OR. So it's important to follow the ALARA principle and make sure that the operator radiation dose is taken care. Now we have all the options from Nomad Pro, from Vatek and Dascoven. So again, we want to highlight that this is important to use, especially because young children cannot really stick to the handheld, to the wall-mounted X-rays. We personally use this machine from Elario. This is made in India product, which works really well. Dr. ABHISHEK has the Genoray over there. Again, it's important to use it. So to make sure that we take X-rays at each and every step. I'm sure you can see a lot of documentation over here, which makes sure that at the end, the X-rays are not missed out in any step. The last but one letter, the young permanent tooth. Again, the highlight important is that we all try to do endodontics, the mature endodontics, so beautiful root canal treatment, the beautiful root canal fills. But at the end, we also have to understand that doing the immature endodontics or the root canal treatment for the immature teeth is equally important. Now with the beautiful materials of bioceramics, MTA, biodentine, new MTA, we can do a one-step technique of apical barrier with a quick setting time, and then restore it, then obturate it, and finish it in one go. So there are American Association of Endodontic guidelines, which is already available. Again, one can go to the literature and review it in detail of how exactly the protocol is. But it's important to manage these cases to make sure that use of PRF, using MTA, using PRF, using centrifugal machine. Now, there are lots and lots of protocols. Gone are the days where we are using only calcium hydroxide, which was the conventional way of doing it. The bioceramics actually gives us a beautiful outcome in the long term. Last but not the least, the Z is for the zirconia crowns. But this is something which I'm sure as an adult dentist, as a general dentist, all of us are very, very well aware of. And I think most of you guys are passed out from the monolithic zirconia crowns. and we are moving towards more of EMAX and lithium disilicate crowns. But trust us, for pediatric dentistry, this has been a huge boon, especially for primary anterior cases over there. And there has been a lot of literature which highlighted that it is readily accepted by the parent, by the child, and everybody loves it. We have a lot of companies from New Smile, from Zicode, from Easy Pedo, from Kinder, and we have also our very own Kidsy crown, which is made in India company. But again, these crowns give beautiful outcome. I just want to quickly go through the case series of the cases where we see the pre-op. If you see the pre-op, you can use any material in the world, it will not give that outcome what this beautiful crowns give. And these crowns are the ones which actually not only promotes stable treatment, but also highlights overall psychological benefit, because see, these are all 3 years, 4 years. The only thing they remember is their teeth, which are mutilated, which are always paining, discomfort, and at the end, everybody is struggling, the child, the doctor, the parents. Once you start using these crowns in a proper case selection way, they give beautiful outcomes. And I think the pictures are there to say. I really don't have to speak on what difference does it make. But I think one thing which we can safely say, that one cannot really differentiate between a primary natural crown and these, and one can see the difference between how does a steel crown conventionally looks and how these tooth crowns actually look like. So we do these crowns under GA, we do these crowns every day under nitrous oxide. Again, posterior crowns can be debatable in the form of parental acceptance and parent affordability. But for primary teeth, as we mentioned, these are no-brainers unless until the tooth really cannot hold on a zirconia crown. See this picture, this case of Dr. ABHISHEK, we really love it. Just see the pre-operative, how it was, and just see the post-operative. I don't think so anything can compare to the outcome what we can achieve with these crowns. So this is phenomenal in my understanding. Again, these are some of our cases where the children come with full-blown SEC, things are pretty much badly damaged, and over the time, the children get the beautiful smile over there. So it's important to take care of the aesthetics for the young ones. They are not just dealing with primary teeth, which will go off. If you can see, this is my own case of nephew, where you can see this whole crown lasted for 27 months, and eventually the crown stayed. Only the tooth get resolved over there. So it's important to provide a good quality care. It's important to provide good quality aesthetics. Children deserve good smile. We are no one to say no to them and provide inadequate care. We want to summarize our presentation by this simple slide, that just because we don't see evidence, it doesn't mean the evidence doesn't exist over there. The takeaway message for this whole presentation is this: pediatric dentistry is a beautiful art and science. Children are the great little people, and they're always full of stories and surprises and keep us on our toes. This is one of our favorite slides, which we try to keep in all our presentation. And there's always a great satisfaction for us when we, with our innovative and ever-evolving approaches, makes an apprehensive child realizes that, yes, I can do this. That's the best gratification one can achieve from this. I would like to take a couple of minutes, if the admin team can give us just last 2 minutes about our program, which we do. Again, as you could probably make out from our presentation, that PedoZen is not any other workshop, any other course. It's basically coming from our heart. We basically try to practice passionate pediatric dentistry. And this is again an offline program primarily, where we actually invite people to our clinics, see whatever we have shown you in this alphabetical journey to actually witness directly. Unfortunately, these are COVID times, and it's very difficult for anyone to travel now. So right now we have our online program going on. And again, you can see the details on Facebook and part over there. But again, this is only for those people who love pediatric dentistry. You don't need to be a pediatric dentist to love pediatric dentistry. That's I think Dr. ABHISHEK and me would agree to say that you just need to love kids and want to do good for them, and then game is on. We are always there to help you, guide you, suggest you. We ourselves are on our own journey. So it's not like we are gray hair and we are 30, 40 years into pediatric dentistry. We're still learning, but we are always happy to showcase and share our work, inspire people, influence people. We have our upcoming program in the coming month. Again, one can go to the Facebook page and get the details. They can contact us through our social media channels. But major idea is that treating kids is always a a love which we cherish. This is Dr. Abhishek and Dr. Sanchit signing off for this WDA presentation. Thank you so very much to the whole WDA team. As we mentioned, Dr. Swapnil, we are always there to break the records. So it's already 11. I'm sure we are probably the longest one, but I hope it was worth staying up for 2 hours. Over to you.
Sanjit, can you stop the screen there?
Thank you, Dr. Sanchit sir and Dr. Abhishek sir. It was a wonderful and eye-opener for most of the dentists who are listening to this presentation. And it's really fascinating. And once lockdown and the COVID times are gone, I would definitely be the first person visiting both of your setups, and probably Abhishek sir's setup is quite near to me. So the first person to go and visit his setup as soon as the COVID times are gone. I would like to get to some questions from the live comment. So probably we'll take one question each. The first question comes to Dr. Abhishek SONI sir. Dr. Priya asks, what if the patient is still uncooperative even after tell, show, do technique?
So then you have the other behavioral management tools in your kitty. So that comprises, if you don't have nitrous, then probably you can go in for oral sedation and try to manage the case chair side. And in case that does not happen, then you can probably have some reinforcements. You can probably just do a motivational visits, but make sure that you're charging those each visits. Let it not be futile. Let the parents also realize the kind of efforts you're putting in to make an absolutely negative child into a positive one.
Okay, thank you, sir. Next question is for Dr. Sanchit, sir. Dr. Kapil Jain asks about the use of MTA for pulp capping.
Okay, so as we have discussed and Dr. Abhishek highlighted detail about bioceramics, so we have to understand that MTA was the first bioceramic or the bioceramic which has been widely used. But now we have more purified forms of MTA in the form of MTA plus, the white MTA which we already know, and the biodentin which is not quite popular. So all these are bioceramics. One can use any form of MTA, any form of biodentin, which is again an MTA with a better setting properties, because a conventional MTA sets in 24 hours. That basically warrants your 2 or 3 visits where we are only doing one MTA procedure, then bring the patient back and doing another procedure. Whereas the newer bioceramics in the form of biodentin, the new MTA, they sets within the 9 to 12 minutes. So basically in the same visit, we can perform our endodontic procedure. It can be anything, buccal repair, perforation repair, your pulp cappings as mentioned, and immediately restore it over there. So one can use any, but we have to remember the manufacturer instruction that what time setting it is allowed. Conventional MTA doesn't give us quick setting time because they don't have the accelerators in the form of calcium chloride, which biodentin does have, or new MTA has. Yeah.
So thank you. I hope Dr. has got his answer. Next is for Dr. Abhishek sir. Dr. Moniba Ansari asks about the irrigation protocol in relation to time and concentration and the solution which you use during the pediatric endodontics.
So we are using a lower concentration of sodium hypochlorite. That's around 1.5 to 2.5% is good enough. Provided you are working on rubber dam, because even if a drop trickles down, the child is going to puke on the chair. So just make sure that you're doing your endodontic therapies under dam. And in case you feel that it's going to be difficult to use sodium hypochlorite, you can switch to 2% chlorhexidine, which you can use at your advantage. So what we are using now is basically something called a spin clean, which we mix with 2.5% sodium hypochlorite, 2 capsules of the same in 10 ml of 2.5% sodium hypochlorite, and we're using just that single irrigant in between our file systems.
It actually does all the action of chelation, your tissue dissolving, bactericidal, and activation of this removal of the smear layer. So it is a combined product, but again, we can use different, as Dr. Abhishek highlighted, the chlorhexidine, the EDTA, and your hypochlorite.
Yeah, thank you. Again, Dr. Muniba Ansari has one very interesting question. What should be the thickness of biodentine in IPC or DPC procedure?
So if you go to crown the teeth, what we do is we fill the entire cavity with bioceramic.
Excuse me, Abhishek sir. There is a lot of echo with your voice. Can you please check for it?
Sanchit, can you take that up?
Yeah, I can quickly take up. So basically what Dr. Abhishek is highlighting and what we generally do, that if your final restoration is a crown, then we can entirely fill the cavity with the biodentine so that we don't have to really reduce that biodentine layer. But in case we are not crowning the tooth and we are just sticking with the final restoration in the form of composite or a GIC, then we fill the depth of the cavity in the form of 2 to 3 mm. That's more than enough because that's actually over the pulp or over the near to the pulp. And then after that, we clean the walls, make sure that there's no biodentine on the wall, and then do our conventional restoration in the form of GIC or a composite. We have to wait for 9 to 12 minutes before doing the final restoration, but that time is generally taken up because once you're done and you're cementing, you're condensing it and then mixing up your restoration. So that would be my our suggestion to go forward for it.
Thank you. Dr. Dhruti Mehta has a very interesting question. We've talked all about motivating our children and everything, but motivating parents to shell that money from their pockets is again very important. So she asked, how do you motivate the parents?
So first thing which, Dr. Abhishek, can I quickly answer this? This is probably my core area. So the first thing which we do is we don't convince them. So I personally, as a practice management person, I personally feel we should talk like cardiologists. We should talk like doctors. I'm sure nobody, have you ever seen a cardiologist actually convincing their patient, oh no, you should get stent, sit there, I'll tell you what is a stent. We never expect a doctor to do this. Or when I say doctor means somebody there's something which is more important. Similar way, our approach should be to be professional, thorough professional, to be scientific. If a patient is coming to you to ask your professional recommendation, you should always give the recommendation. And if the parents say that I am not comfortable about it or I don't wish to get it done, then our aim is not to actually convince them. Our aim is actually educate them. Tell them that what is the reason you don't believe in. If they say, I don't know about it, give them the resources, give them the links, give them the things which actually make them understand. Because see, the moment we take the onus of, oh no, you should do it, I personally believe it, and doing all those things, there where the mistrust happens, and if things doesn't go right, the mistrust happens. But motivation is basically also can be done by your own cases. I'm sure the way you have seen the videos and cases, if you showcase your own work, I find parents accept it very readily because they know that whatever I'm being shown is a standard work. So a good work documented well and communicated well doesn't need much convincing. It just needs good intention.
Okay, that's quite correct. Thank you. On this point also, I would like to request both of you had very good videos during the presentation. We would request you to post them to our group World Dental Association so people can watch them at ease and learn a lot.
Yeah, so we have been trying to do this. Yeah, we have been trying to do this for the last, I think, few weeks, Dr. Abhishek. But all these videos again are available on our own pages on our YouTube channel. Okay. But we would be happy to keep posting whatever we keep on making in the future times.
Yeah, if possible, you can directly post the videos rather than posting the YouTube links.
Okay.
It means have been not allowed to do other channel promotions. So we can directly post your videos also. So we would be more than happy. My next question would be, what is your take on lasers versus electrocautery? Because people practicing a 3-tier town like me cannot afford a very high laser. So can we use cautery for the same?
Yeah, Dr. Abhishek.
So with cautery, if the child moves, you will realize that the depth of cut can get very deep. Whereas with the laser, it's going to just go into depths minutely and in a stepwise manner. Second is that you will achieve much better hemostasis with your lasers as compared to your electrocautery. However, your cautery also has a hemostasis option with it. So you can go ahead with your electrocautery at a lower gradient That's around 1 to 2, but make sure that you have a firm hand when you're going in with your clipping or your for your frenectomy procedures.
I would also like to
Okay.
add one point, which where we sometimes miss out. That see, cauteries are fine for your adult patients and for those patients who are probably can cope up. But you have to understand that although we haven't included that in our this presentation, but and Dr. Abhishek shown it in few cases that when we're doing a frenectomy for infants, for 10 days old baby and 12 days old baby, our aim is to actually achieve a very quick target in a very short span of time. Now, cautery is something which is not very comfortable to do that. Secondly, the cautery never gives you the biostimulation. It only does the coagulation part, the thermal effect. The other effects are not missing in that cautery. So again, for general dentistry, for general uses, cautery serves some purposes, but laser, especially with the component of low level laser therapy, which actually takes care of your ulcerative lesions, your lip bites, your trauma, those things are all taken care by laser. So again, it's a one-time investment, but it serves the purpose, what it's meant for.
Thank you. Thank you. Now, once we've come to the point, I would like to request you to please share us the cost of nitrous oxide inhalation. If someone wants to start doing it into their practice, what is the initial investment he has?
Yeah, so I can quickly take it up. See, again, this is a topic which is very, very widely discussed because, again, depending on what machine we are buying, because see, there are two type of machine. One is the which is being imported from outside. The ones like Porter Matrix or the Accutron, which is actually all US made and being imported. Now, the costing usually range from 3.5 to 4.5 lakh, depending on the dollar conversion. But it also constitutes a big amount of import money, import duty. Whereas now we also have options which are available in India as an indigenous units. Again, they might not be as branded or as uh, marketed as the way which is international, but they serve the purpose. So again, as we all say, it is one-time cost. Depending on your budget, your inclination and your affliction, you can buy the unit. Those indigenous units actually start from 2.5. But again, everybody has their own choice of what units they want to procure. There are digital units, there are analog units. Again, I would say do the proper homework. You can always visit someone who is practicing it and get in touch with them. We actually touch base with this topic in our own session because this is something which we can speak for hours. But one can do the homework and then buy the unit. It is available, but again, as you might have seen, it is an amazing practice builder. So whatever money you're gonna invest, I think both Dr. Abhishek and me would agree, it's the biggest return of investment you can get from that.
And you can charge your sedation visits. Second was whether your system is centralized or it's
Or
not.
portable.
So if the system is centralized, all you need is the head of the unit. So the mixer does not cost more than 1.75 to 2.5 lakhs. So that's what we have is a centralized system. So that's how we cut down on the yoke, basically, is what you don't need in case of a centralized system. So if you
So again,
are,
there's a lot of things over there.
so if you're keen on doing a sedation practice wherein all your children, most of your children will be treated under nitrous, then it's better to opt for a centralized system rather than
Portable system. Yeah. So cost varies depending on which type of system you're going for and what type of mixer you're getting.
Okay, thank you. One last question from Dr. Karuna. The role of SDF in permanent teeth.
Okay. Dr. Abhishek, you want to quickly take it?
So for permanent teeth, we've used it in MIH cases. There are two ways of application. You can either do a 6-monthly application, that is a biannual one, or you can do an intensive SDF application for your MIH cases, your molar incisor hypoplasia cases, hypomineralization cases. Now, what happens with SDF is it also acts as a desensitizing agent. Now, I don't know how many of you have attempted treating an MIH molar. You will realize that when you touch the drill to the tooth surface, even under optimum anesthesia, local anesthesia levels, the hyperinflamed portion of the pulp does not really get optimally anesthetized. And that's the reason why they will always feel that pain. So what we do is before we actually go in for the crown preparations for the MIH treated tooth, we do a few applications of SDF, desensitize it, and you can see a drastic difference when you're actually treating the child for the crown, the child does not feel that kind of pain, which the child would have without the SDF application.
Yeah, so basically SDF acts as an IPC agent, as a pulp capping agent, Dr. Abhishek highlighted, and anything which is going to be crowned eventually, because most of the MIH molars will be crowned later on because of its deterioration. So that the silver effect of SDF would eventually be masked. So in those cases, actually it is better to use SDF as a desensitizing agent and then eventually crown it later, so that your both the purposes of caries arrest and your final restoration is taken care.
So thank you. I hope we are done with the questions also. If at all any more questions, conveying it to you and answering them on the comment section whenever they come, maybe in a day or two. Again, I'd like to request you both to please put your detailed videos on our, so we can keep the learning mode active up. And also, I'd like to share this to all our viewers that the complete session shared on YouTube also on our channel World Dental Association, so people can watch it at their ease later on also. Once again, on behalf of World Dental Association and all the team and all the members, 98,000 members across the world, we would like to thank Dr. Sanchit Paul and Dr. Abhishek sir. Probably in this complete lockdown, in this complete Corona times, pediatric dentistry was one topic which was not much touched, and you people really just touched the topic, but touched every viewer's heart. And thank you so much. Thank you for practicing such wonderful pediatric dentistry, and thank you for giving us such wonderful knowledge session. Thank you so much, and goodbye, good night to all our viewers. Thank you. Good
Thank you so much for having us on over there.
Thank you. Good night.
Good night. Thank you, Dr. Ashwani.
Good night.
Good night.